Hey gang, welcome back. We've got a potential practice changer, so once again, it's time for a rapid response. Today we'll be talking about PIPPEN, a study released in March 2026 that sought to explore the cross-reactivity, or lack thereof, of penicillin allergies and Piperacillin-tazobactam. Their primary outcome was the proportion of patients with a labeled penicillin allergy that tolerated a dose or more of Piperacillin-tazobactam. Citation 3 in the background by Lee and colleagues from 2012 brings up some interesting stats. Penicillin allergies are the most common med allergy with a prevalence of around 10%, but up to 95% of these allergies are not true allergies. In the background, the authors highlight the R1 side chains are typically to blame for cross-reactivity. In this handy chart from Zosyn and colleagues from 2018, many of the commonly used penicillins and cephalosporins appear here, but piperacillin is nowhere to be found. In an MCRIT article about this topic, piperacillin and nafcillin are both highlighted to have unique R1 side chains, so it's fair to not anticipate any cross-reactivity. Josh Farkas has been saying this for years, but we may finally have some more solid evidence to back it up. However, other studies have suggested caution when some penicillin-type allergies exist. This retrospective skin testing study by Salinero and colleagues noted a 17.9% chance of cross-reactivity between the 28 amoxicillin-allergic patients included in their study that received pip/tazo skin testing. The authors caution that a shared D-alpha-phenylglycine portion of the side chain could serve as a possible source of cross-reactivity. Certainly interesting, and the relatively high cross-reactivity shown here is a little discouraging. While doing some research, I noticed AI tried to take a stab at solving this problem too, but swing and a miss. Piperacillin and cefazolin do not share a similar side chain as stated here, and neither of the resources cited include pip/tazo in their cross-reactivity tables. ID Stewardship simply states there isn't data for cross-reactivity on pip/tazo at all. Thanks for the write-up on that one, Farmer Meg. Definitely look her up on Blue Sky or check out her research. Lots of great stuff to learn there. Online cross-reactivity resources like this one from Northwestern still advise caution, citing a similar side chain. Their citation for this, the 2022 Drug Allergy Practice Parameter Update, cites many of the studies that the PIPPEN authors do as well. Back in the PIPPEN background, the authors highlight this evidence, but state that all of the studies included a minimal number of patients and all focus exclusively on skin testing results, not use in clinical practice. PIPPEN was a retrospective chart review at a single center covering a little over 2 years. Patients were included if they had a documented penicillin allergy and received at least one dose of Piperacillin-tazobactam. Exclusions included patients with completed skin testing, those discharged within 24 hours of their first dose, a history of tolerating the drug, or intolerance-type reactions such as nausea or diarrhea. A challenge was considered successful if patients tolerated at least one dose of Piperacillin-tazobactam without an allergic reaction noted in the progress notes. Notes up to 5 days after the first administration or until discharge were reviewed, whichever occurred first. According to the authors, this duration was selected as delayed hypersensitivity may occur up to 4 days after antibiotics were administered. If patients had a reaction, additional data were collected, including time to intolerance, features of the reaction, and other meds likely to cause allergic reactions that were given within 48 hours. Again, the primary outcome was the proportion of patients that tolerated pip/tazo, with a secondary outcome focused on different risk stratifications as outlined in the Fraser Health Authority risk stratification for penicillin allergies. The FHA stratifies the risk of penicillin allergies into 3 categories: low-risk delayed reactions, high-risk anaphylactic reactions, which also include poorly described symptoms but is in patients with cardiac or respiratory comorbidities, or well-documented delayed reactions. Interestingly, drug-specific reactions like hemolytic anemia, agranulocytosis, or neutropenia are noted to be unlikely to cause cross-reactivity, and FHA suggests only avoiding the offending drug. Some baseline characteristics of interest include the noted allergy. Most were specifically penicillin, with a general penicillins group responsible for another 26%. The date of penicillin allergy onset was mostly unknown, with another 20% occurring over 10 years ago. The hypersensitivity classification for the allergy was almost entirely unknown as well, and patients frequently had no other antibiotic allergies. Overall, this population seemed to be at a low risk for cross-reactivity based on these characteristics, but considering the previously discussed high rate of non-allergic patients with recorded penicillin allergies, this may just be an accurate representation of penicillin allergies in the wild. 191 patients were included, with a nearly 50-50 split of low-risk and high-risk reactions. Only 2 patients had well-documented delayed reactions, precluding us from drawing any conclusions about this portion of the population. 29 patients had documented anaphylactic or similar reactions, including shortness of breath, angioedema, or swelling, population that I have definitely been more cautious with in my own practice compared to less severe reactions. 187 of the 191 total patients, or around 98%, tolerated pip/tazo for at least one dose without any documented reaction. All 29 patients with a history of anaphylaxis-type reactions to penicillin tolerated pip/tazo. Some background was provided on the 4 patients that had reactions to pip/tazo. An Naranjo score correlating with possible ADR was calculated for 3 patients, and a probable reaction was for the final patient. All patients had received other antibiotics, including cefazolin, metronidazole, meropenem, and cephalexin, within 48 hours of reaction. Only 2 patients required any treatment, and all reactions resulted in immediate recovery and full resolution of symptoms. In my practice, I had avoided using pip/tazo for patients that had penicillin allergies, but I'm certainly reconsidering that now. We're not at ANSEF for all levels of confidence quite yet, but for patients with low-risk delayed reactions or high-risk anaphylactic reactions as described in the study, a dose of pip/tazo is probably appropriate, so long as we're not forgetting to check if we actually need the broad coverage first. The question still remains for patients with well-documented delayed allergic reactions, which were underrepresented in the study. This study and PALIS, a positive RCT of oral penicillin challenge versus standard of care for patients with low-risk allergies cited in the study's discussion, give us a pathway to get more patients on preferred beta-lactam therapies instead of likely inferior alternatives. But what do you think? Does PIPPEN convince you that pip/tazo deserves a second breakfast for penicillin-allergic patients? Or should we leave Zosyn back at bag end until there's more data? I think it's time to change my practice, but don't take my word for it. Check the description for the relevant studies and decide for yourself.